Hello everyone, I am Dr. Radhika Sridharan from the Department of Oral Pathology. Welcome to today's session on the topic development of face. So in today's session we will look at how the upper lip, cheek, ear, eye, palate and the tongue and some of the clinical aspects related to this. So now first let's look at how the upper lip is formed. So in the early development we have two key structures, that is the medial nasal prominences which will be present in the center and the maxillary prominences on both the sides. As the face grows, the medial nasal prominences move close together and fuse in the midline. So this fused part becomes your central region of the lip, so which is called as the philtrum. So the vertical groove you can see just beneath the nose. Meanwhile, the maxillary prominences grow forward from each side. They meet and join with this medial nasal prominences. So they meet and join with the medial nasal prominences. This fusion completes the lateral part of the upper lip. So the upper lip is actually a combination, the central philtrum from the medial nasal prominences and the sides from the maxillary prominences. If the delicate process of fusion fails during some stage, it results in the cleft lip, which can be on either on one side or on the both the sides. So now let's look on how the cheek develops. The cheeks are formed when the maxillary prominences above join with the mandibular prominences below. At first, the opening of the mouth is quite wide and large, but as these processes grow towards each other and fuse, the opening becomes narrower and takes its normal size and shape. This merging not only forms the cheeks but also helps define the boundaries of the mouth. So now let's look on to the next topic on how the ear develops. The ear is a very interesting structure because it doesn't come from a single source. Instead, it has external, middle and the internal parts all arise from different embryonic origins. So in this slide we are focusing mainly on the external ear. So if we look at the diagram, you can see the first pharyngeal cleft, the dorsal or the upper part of this cleft deepens and eventually forms the external acoustic meatus, which is the ear canal. So around this cleft, 6 small swellings which are called as the auricular hillocks appear, 3 on the first arch and 3 on the second arch. So these hillocks gradually fuse together and give rise to shape of the auricle or the pinna, which is the visible part of the ear. So the middle ear bones also have their origins here. The malleus and incus develops from the Meckel's cartilage of the first arch. The stapes develops from the Richard's cartilage of the second arch. So the external ear comes from the first ectodermal cleft, while the important middle ear bones trace back to the first and the second arches. So this is also one of the earliest sensory organs to start developing in the embryo. So the ear is unique because it develops from 3 different parts of the embryo, as we have already seen. So just a recap, so the external ear comes from the first pharyngeal cleft. So this cleft deepens to form the ear canal. The little swellings around it fuse together to create the auricle or the pinna, the part that we see outside. So the next is the middle ear. It arises from the first pharyngeal pouch. This pouch expands to form the tympanic cavity and the eustachian tube. Inside the tiny ear, bones develop, the malleus and the incus from the first arch and stapes from the second arch. So finally, the inner ear comes from otic placode, a thickening of the ectoderm near the hindbrain. So this sinks to form the otic vesicle, which later shapes into the cochlea for hearing and semicircular canals, which is important for balance. So this is another picture which will give an idea of how the external ear develops and the middle ear bones develop. So ear is also the first sensory organ to begin development in the embryo. So now let's move on to the development of eye. The eye actually starts as an outgrowth from the forebrain called the optic vesicle. When it meets the surface ectoderm, a thickening called the lens placode forms and folds to make the lens. So the optic vesicle itself folds into a double layered optic cup. The outer layer becomes the pigmented retina and the inner becomes the light sensitive retina. So the optic stalk connecting to the brain develops into the optic nerve. This is about the eye. So now let's move on to the important topic, which is the development of palate or palatogenesis. So which is your roof of the mouth. So this process begins towards the end of the 5th week and is completed by 12th week. So the most critical time is between the 6th week and the 9th week, when most of the fusion takes place. So the palate is basically of two parts, the primary palate and the secondary palate. So just imagine, think of it like constructing a bridge. So the primary palate is like a first small platform which is found in the front. Then from either side you have the secondary palatal shelves that grows out. At first they hang down on the sides of the tongue. Later as the jaw grows, when the tongue drops, these shelves swing up and meet in the midline and fuse together and they close. By the end of this process, the primary and the secondary palate joins to form the continuity of the roof, separating the oral cavity from the nasal cavity above. So in some stage, if this delicate fusion doesn't happen in a proper way, or if there is a discontinuity, it may lead to cleft palate. So now let's zoom into the roof of our mouth, the palate. So it's not just a flat bony plate. The palate is divided, as we have already seen, the primary palate and the secondary palate. As you can see in this image, the primary palate is a very small triangular portion that lies in front of the incisive fossa, almost like a front porch of the palate. So behind it stretches the secondary palate, which forms the majority of the hard palate. And then it continues as the soft palate. So even though the primary palate looks tiny in the adult, it plays a crucial role in the development. So it is the very first part that forms and sets the stage for the rest of the palate to develop and fuse properly. So now let's look deep into the primary palate, how it actually forms. So around the 6th week of development, a small structure called intermaxillary segment gives rise to the median palatine process. So this becomes your primary palate. You can imagine it just like a first foundation of the palate. It sits just behind the premaxillary part of the maxilla and later it must fuse with the growing secondary palate. So even though the primary palate is very small, it plays a major role for the rest of the palate to develop. So this secondary palate actually forms the bulk of the hard and the soft palate just behind the incisive fossa. So the development begins around 6th week when the shelves called the lateral palatine process grow inwards from the maxillary process. So initially they hang down vertically on either side of the tongue, but as the embryo grows, these shelves elevate, move horizontally and fuse with each other and also with the nasal septum. So this fusion creates a proper separation between the nasal and the oral cavity, which is essential for breathing, swallowing and also speaking. So if you look at this picture, in the beginning, the lateral palatine shelves project downward on either side of the tongue. As the jaw grows, the tongue gradually descends, creating a space. So by around 7th to 8th week, the palatine shelves rise up, swing inward and they position themselves horizontally above the tongue, which is ready to fuse. So in the next picture, you will be able to see once they are in position, the lateral palatine process start moving medially. They approach each other in the midline and when they meet and they fuse together, they form a continuous palate. So this step is crucial to establish a barrier between the oral and the nasal cavities. So it doesn't stop with that. The shelves also unite with the posterior part of the primary palate in front and with the nasal septum above. So this completes the roof of the mouth and giving us the functional hard and the soft palate. So as we have already seen, any disturbances can lead to cleft palate abnormalities. So this image will give you an idea how the primary palate is formed and what role does the lateral palatal processes play. and how it fuses with the nasal septum and also with the primary palate in front. So in the next image, we'll be able to see how the palate takes its final shape. So at first, the palatal shelves lie on either side of the tongue and the tongue drops down, and these shelves swing inward and fuse with each other and also with the nasal septum. So notice how different regions contribute to the palate. So the primitive palate from the frontonasal process forms the premaxilla, while the palatal process from the maxilla forms the hard and the soft palate behind it. So now let's look at intermaxillary segment, which is quite important. So when the two medial nasal prominences grow and merge both on the surface and deep inside, they form this intermaxillary segment. So this intermaxillary segment has three important parts: a labial component which forms the philtrum of the upper lip, and an upper jaw component which carries the four incisor teeth, and a palatal component which forms the triangular primary palate. So this structure is crucial for the normal development of the midline of the face. So failure of its proper development can contribute to conditions such as cleft lip or palate. So now let's see how the tongue develops. So in this picture, you can see the tongue starting to form around 4th week. Notice the two yellow side swellings that you can see in this picture. These are lateral lingual swellings. So in the midline, there is a purple swelling called the tuberculum impar. All the three come from the first pharyngeal arch. As the side swellings grow, they meet and fuse together, covering the midline swelling. So this fusion forms the anterior 2/3 of the tongue, or we call it as the oral part of the tongue. So in the next image, you can see how different arches contribute to the development of tongue. So the pink area at the front is from the first arch, the part we just saw as the lateral swellings. So behind that, the blue part comes from the third arch, forming the posterior 1/3 of the tongue. And finally, you can see a small green region at the back from the fourth arch, so which makes the root of the tongue. So together, they fuse together and form the tongue organ. And this is how you can understand how the different arches contribute to the development of tongue. So each part has a different nerve supply. So at the junction of anterior 2/3 and the posterior 1/3 of the tongue lies a groove called the sulcus terminalis. So the tongue receives rich innervation from multiple cranial nerves. So anterior 2/3 of the tongue is supplied for general sensation by the mandibular branch of the trigeminal nerve, and the posterior 1/3 is by the glossopharyngeal nerve. Motor innervation is done by the hypoglossal nerve. And the most important part is special sensory taste sensation for the anterior 2/3 is by chorda tympani branch of the facial nerve. So together these nerves allow the tongue not only to perceive touch, pain, temperature, but we can also appreciate the taste. And also it plays a role in speech and swallowing. So far we have seen how the development of face happens. So now let's quickly see some of the clinical aspects. So as you can see in this picture, so this is where classification system helps us understand how the different patterns of the cleft palate. So in type 1, it is the simplest form. You can see only the soft palate is affected. So in the type 2, you have both the soft palate and the hard palate extending up to the incisive foramen is affected. And type 3 is more extensive, a unilateral cleft of the soft and the hard palate continuing to the lip and the alveolar ridge on one side. And type 4 is more severe. You'll be able to see bilateral cleft of the soft, hard palate, lip and alveolar ridges on both the sides. So as we move from type 1 to type 4, the cleft progresses from a small split at the back of the mouth to a complete bilateral division involving both the lip and the palate. So this is another classification, Kernahan's classification. This gives us a clear way to describe the exact areas affected by a cleft. So think of it like a numbering system from 1 to 9. So each number marking a specific site. So 1, 2, 3 covering the right side, that is the lip, alveolus and the premaxilla. 4, 5, 6 on the left side of the lip, alveolus and the premaxilla. And 7, 8, 9 represent the hard palate, soft palate and the submucosal cleft. So by using this cleft map, we can pinpoint whether the defect is on the right side or on the left side or midline, and we can standardize it. So in short, this classification is like a map helping the surgeons and the clinician speaks the same language and diagnosing and better for a planning treatment. So in the next image, some of the clinical examples of midline facial clefting are shown here. So in the first child, notice the absence of intermaxillary segment leading to a wide midline gap. So this results in features like absent premaxilla, incisors and the primary palate along with hypotelorism where the eyes are abnormally close together. This type of defect carries a high risk of serious brain anomalies. So the second is an example of true midline cleft of the upper lip and philtrum. And finally, the lower images highlight the midline cleft lip in association with some syndrome like Mohr syndrome. So these pictures remind us that midline cleft is not just a cosmetic issue, but it is a window for an underlying syndrome or some neurological conditions. So in the next image, we can see a spectrum of facial clefting in real patients. So in image A, there is a right unilateral cleft lip and palate in a newborn. Notice how the cleft extends into the nostril base and distorting the intermaxillary segment. So in the image B, it is quite severe case, a bilateral cleft lip and palate in a 4-year-old boy. So the growth of the intermaxillary segment is disorganized, leaving the premaxilla protruded and the alveolar ridge also gets displaced. So in the images C and D, it demonstrates how it appears before and post-surgical. So the bilateral cleft prior to surgery and D after the surgery. You can see how it is restored. So in this image, we can see a child with a bilateral oro-ocular clefts combined with a bilateral cleft lip. So in the frontal view, you can see the clefts extends from the upper lip all the way to inner corners of the eye, creating a dramatic communication between the oral and the orbital region. And the nose and the philtrum are also severely distorted, reflecting the failure of fusion along the embryonic maxillary and the frontonasal process. So in the second picture, that is the lateral view, it highlights the depth and extent of the cleft, showing how the normal facial contours are disturbed due to this from lip to eye region. So this clearly demonstrates how any disturbances in early embryonic fusion can produce these kind of complex craniofacial deformities. So in the next image, you'll be able to see different facial types of median cleft face syndrome as described by Sedano. So in image A, you can see a 3-month-old infant with a clear midline facial cleft affecting the lip and the face. And image B represents in a newborn only just 4 days old, where the midline, in the image B, it shows in a 4-day-old child where the midline defect is more striking and disrupting the continuity of the upper lip and the philtrum. And the image C, you can see image C in a young boy after the surgical repair of a bilateral cleft lip and palate. So in spite of surgery also, the midline facial dysmorphism remains visible in this child. And image D, it is seen in a 3.5-year-old boy with severe midline defects, including broad nasal deformity and clefting. So together these images illustrate the spectrum of severity in median cleft face syndromes. So this is another example of craniofacial anomalies. So in image A, the child has microtia, the external ear or pinna is clearly malformed, but otherwise the face appears quite normal. This shows a localized defect can primarily affect the ear alone without much involvement of other structures. So in the image B, you can see a child with a case of hemifacial microsomia. Here the entire right side of the face is smaller, including the orbit, eye and the jaw. So the pinna is also underdeveloped, and the facial lines formed by the eyes and the mouth converts towards the deformed ear. So this is an example of the classical features of Treacher-Collins syndrome in an 8-year-old boy. So this is an image of 3D CT scan. So you can see the frontal and the lateral views. We can see the hallmark features here, that is the malformed ears on both the sides and a distinctive down slanting anti-mongoloid appearance of the eyes and malar hypoplasia and an hypoplastic mandible. At the same time, the central face looks over projected, creating a characteristic facial imbalance. So these cranial changes are not just cosmetic, they contribute to functional problems like breathing, feeding, hearing and speech difficulties. So this is the final image, clinical image of a 3D CT scan of a 21-year-old boy with Peary-Robin sequence. So you can see the classical features like severe retrognathia, micrognathia, and also if you can see in the image C, the coronal section, you notice the buttressing around the mandibular condyle, suggesting the body's compensatory mechanism remodeling efforts. And in the image D, the axial view highlights while the maxillary incisors are vertically oriented as expected, and the mandibular teeth follow an almost horizontal closure, showing how the jaw growth discrepancy impacts the dental alignment also. So together these images capture the characteristic craniofacial profile of Peary-Robin sequence, where an underdeveloped mandible actually disrupts the normal facial balance, occlusion and also the function. So facial development is a delicate interplay of embryonic events, and even a small disruptions or any kind of disturbances can lead to profound anomalies, craniofacial anomalies. So these cases remind us how embryology shapes clinical reality, linking growth, function, occlusion and form. Thank you.